So with that, I would like to hand it over to Dr. Anil Rudskeep, who is the director of our Herbert Irving Comprehensive Cancer Center, to moderate and lead a discussion.
Thanks, Dr. Cantos. So I want to keep this informal for our panel discussion. So I'll lead off with some questions to each of them. Some of them may be targeted to some of them, but would definitely like to open it up to you in the audience to ask your questions and make any additional comments that you have. So I think you've met everybody who's on the panel has spoken, except to introduce my colleague, Dr. Murdoch Riley, who's Vice Dean for Clinical and Translational Research and also Director of the Irving Institute for that type of research and Director of our NIH CTSA. So let me start off with each of you, and we'll start with Dr. Carlos and go around this semicircle. Where do you see the most exciting opportunities for AI in radiology and medical imaging that have opportunities to change medicine as well? Dr. Carlos, we'll start with you.
Wow, such an easy question to start with. What interests me is how AI actually can change potential skill levels of those who use it, both upskilling and, unfortunately, deskilling. It also holds potential promise for how institutions, such as healthcare systems, can use AI to predict workload, predict system load, in order to become more nimble and to build resilience into the system as there are increasing clinical care and other mission demands.
Testing, okay. This is probably a function of my background. I did my PhD in biomedical natural language processing, focused on information extraction from the scientific literature. And one of the big things that's happened with the advent of LLMs in the last few years is that just natural language inference from text has gotten so much better. It's night and day. So what I mean by that is so much of information in healthcare, especially around clinical outcomes, is still contained in unstructured text. And so we can have all the structured information we want in the EHR, but if we want to know what happened to a patient, we often still have to go to the notes, and it's a real bottleneck. And these technologies really have the potential to actively read text, human read, and extract. You can ask questions of them and extract structured information about different patient outcomes, social determinants of health, and other things that were really hard for us to extract before. And that just opens the door for tons of different associational studies, with linking imaging to different outcomes, different clinical outcomes, different social factors. So I just think it might be a little boring. I mean, I'm not really worried about the Terminator in this space, but I think just the raw technical power of some of these new LLMs really opens the door to using text in new ways, which is transformative.
So I'll just keep with the theme of what's of interest to me at some level. So I'm a cardiologist by training, and although radiology and cardiology have a lot of imaging, they need to be obviously in a collaborative space together. But I'm a preventive cardiologist at heart, and I think the ability to kind of use imaging data as well as large-scale kind of just clinical data to be able to look at kind of predictive and preventive approaches to clinical problems. Whether it's use of the echoes, whether it's use of CT scanning for coronary calcium, whether it's use of chest X-rays. So that's one area, is like how do you bring it together and how do you link it to clinical decision support, which brings in text algorithms, but brings in this clinical data and pathology and laboratory data. I will say that we're sitting in a medical center that we have lipid values on millions of patients at some level, but we don't algorithmically use those to identify FH in our system, for example. So there's this tremendous amount of things we can do individually, but linking it together for prediction and prevention. Number two is, I think, on the research front, we've heard about it earlier, but the ability to link image data, genomic data, text data, clinical data, and other types of data just will accelerate discovery and will actually, I think, create new opportunities for discovery science that also bring in kind of computationally as well as directly biology and imputed biological parameters from single cell to other types of biology for smaller numbers of individuals that can be mapped to large numbers of individuals. And last is education and training. I think we heard a little bit about that, but I hope that we can scale up rather than scale down. But I think training our physicians of the future and our workforce of the future, not just physicians, with the use of AI, can actually really, really accelerate our healthcare systems. So the education training side, I think, is fundamental, and I won't recognize what that looks like because it's probably beyond the scope of what I can imagine right now. But I think it will change how we train people and what they're able to do.
Absolutely. From a data perspective, I think with the correlation of those data sets and the connections that we wouldn't otherwise be able to infer is rapidly accelerating, right? AI is bringing the capabilities to connect those data sets that we never even thought were interconnected. Secondly, I think the acceleration of translation of that into, from theoretical into practice, right? As we think about code-based automation, that the capabilities there are accelerating rapidly. And as we start to translate some of the research and bring those applications to bear, how are we helping that journey from an accelerated code-based perspective?
Well, if AI can be faster and smarter, radiologists can start to take lunch. It's a pretty lofty goal. But in all seriousness, I think that one of the most exciting things to me is that it has potential to engage patients in their care in a totally different way, because it can, with LLMs, for example, teach them new things in maybe more effectively communicated ways than we say sometimes as clinicians, and to help answer their questions or to even offer them questions they might think about asking. And so when it comes to radiology, to have patients understand, what their images are showing, I think could be transformative for the role of radiology.
What can I say that hasn't been said? All right, so AI is industrialized pattern recognition, right? The cool thing about it is that it can operate on inputs that humans can't perceive or can't synthesize. So that offers the ability, and the reason you recognize patterns and make measurements is for decisions. So this offers the possibility that you can optimize every care decision using all of the data that the patient brings in, including data that humans can't perceive, like radiomic patterns or nuances in digital pathology that humans can't perceive. And everything, bring it all together. So that's kind of, and if obviously, from my parochial view as a drug developer, better decisions and, as I described in the development pipeline. So better decisions, fundamentally, about care and about drug development.
Great. Thanks to each of you. Let me reverse the order. Where would you like to see AI help the most in the clinic from a practical, daily, operational viewpoint?
I think I'm sufficiently out of the daily read workflows now that I'm going to pass this off to...
You have a lifeline, so you can pass it to...
I'm going to pass this
Dr.
off to a clinician colleague.
Okay. I want to say that without removing the critical, core of communicating between the radiologists and the referrers, one of the most exciting areas, I think, is to just much more efficiently and in an automated fashion link what the diagnosis or the suspected diagnoses are to the next steps in clinical care, right? So let's just get the order palette ready, right? Let's just have it templated out for the ordering clinician to get it and to move on to the next step rapidly for patients. And we all know, we're patients too, our families are full of patients too, and so this is something that I think in daily operation would be tremendous.
Any thoughts? Probably a better question. Dr. Riley?
Pass it back first, because I think she's in the clinical cold face.
I'm not. Actually, on the agenda, an additional degree was granted to me. Not an MD. Can't save anybody's life. I can say I think ambient scribes are really exciting and potentially transformative. It seems like that just talking to a lot of physicians who actually are in the clinic. That's like a technology that everybody seems to really think can help improve their efficiency, accuracy, better contact with the patient, more kind of eye contact and all of that. So that's an area that I'm personally, excited about.
Dr. Riley, thoughts?
Yeah, I think, efficiency, which also then leads to, improved care, because there is a focus on, rather than spending so much time kind of pulling out all the different individual things, you've got it all algorithmically pulled together. And I think just also then patient engagement directly, as we heard about, like there's just ways that patients can engage through their image data, and with LLMs probably that we explain to them what's going on in a way that by the time you're interacting with a patient, they already have a lot of information. So, and I think that, as I say, pattern recognition for me is all about, like, to some extent, identification of a problem before it arises, whether it's cancer or heart disease or whatever it is. And there's just tremendous potential to use imaging for prediction and prevention in a way that we typically have not been able to invest in or operationalize for financial, but also for just structural reasons. And there's an opportunity here that's just make it automatic.
Dr. Carlos?
As Dr. Kang mentioned, we're all patients. My dream is for every patient to be able to whip out their phone, have it on, have their clinician tell them what is happening, have the AI automatically translate for them in their own vernacular the meaning of what the conversation is, and even suggest to them potential questions that they might be able to ask their physician in order to increase their understanding. At the same time, I also want to make sure that the AI mechanism is available to everyone who needs it, provides accurate information, and allows the clinician to actually do what they are supposed to be doing, which is to take care of the patient.
Great. For my Columbia colleagues, the translation of AI methodologies and tools into the clinics, successes, challenges, what can we do, continue to do, what can we do better? I'll start with Dr. Carlos. From your recent experience, but not only at Columbia, but at University of Michigan where you were before, are there any lessons learned?
Data is queen. And one of the things that we are addressing and need to continue to address is the robustness and representativeness of the data that we collect, but also being able to bank sufficient samples that we may ask questions that we have not even anticipated wanting to ask. We have lots and lots and lots of data, and they exist in multiple pots. The problem is science evolves, and the questions that you want to ask now were not necessarily even thought of before that we would have asked the right question or collected the right sample. And if we can have enough forethought, or at least enough banking capacity to have samples for the future, I believe that may ultimately be a great contribution to medicine.
Dr. Riley and then Dr. Kang.
What Columbia can do to support AI research.
And lessons, when you were at NYU, lessons that we could extrapolate from that time period as well, from when you were there.
I mean, I think that maybe one of the things that I experienced that was tremendously helpful was just a top-down vision of understanding from a very high level what the health system is prioritizing and interested in doing. And then very rapidly moving to designing that system, designing a timeline to build that system in an interdisciplinary fashion, and to have the touch points to, get it to come to fruition. And that, I think, created a lot of opportunities for learning too, for a lot of individuals who become involved.
Yeah, so I think that noise in is noise out. So some of the challenges we have with any data science is to make sure that the design the design and the and the inference is executed scientifically. So data science in these areas are really a team science. You know, and there's certain challenges, as we know, when we're trying to get investigators engaged in using clinical data, either extracted EHR data or image data or omics data that might be coming from the clinics, biobank data and stuff like that. So, you know, there's a certain approach where you think about there's a clinical specialist, there's a computer scientist, data scientist, there's a biostatistician, and then there's an operational person or an operational EHR or specialist in imaging. And that's the kind of team that's needed to design the work and the questions to be asked, and then the algorithms have to be tested and validated and then federated, you know, to test across systems. And I think that's where the challenges are, is right now in a lot of the applications of the stuff from research into the clinical practice.
Dr. Percha, put on your hat on behalf of NYP, challenges and therefore opportunities for clinical implementation of AI in patient care, sort of a macro view and how to get it into daily patient care.
Yeah, so again, not an MD here. I actually think, I was thinking about this earlier, and I think one of the greatest challenges we have right now is actually just general inconsistency in terms of how people define AI. There's a lot of froth. I think if you asked a lot of people, they would think it was invented in 2022 with ChatGPT, but actually these methods predate. And what we're actually seeing from an AI governance perspective is that a lot of the technology, like legacy technologies, are being rebranded as AI when it already existed well before. I think the challenge there is actually more on the regulatory side. You know, I've attended a couple of meetings with one of our regulatory bodies, and folks are still kind of figuring out how these technologies are going to be regulated at a national level, also at a state level. And so there are risks there if we aren't really specific about what AI is and the challenges that the new challenges that it creates, and also what it's doing that's just kind of boilerplate stuff like InfoSec and things that we were checking anyway. If we get too unclear about that, we risk kind of creating a regulatory environment where we will either under-regulate, so we have potential loss of patient data, or we'll over-regulate, in which case we'll stifle innovation in the space. And so I think just getting really crisp on what we're calling AI, how we're regulating it, both from a governmental perspective, but also internally at our health system is very, very important. That clarity is very important.
Great, thank you. Dr. Khalil, Dr. Goldmacher, near-term, long-term academia-industry partnership relationships and attacking the issues that we're discussing. Your thoughts on that, Dr. Khalil, and then Dr. Goldmacher?
I mean, I guess establishing ways of sharing data through federated platforms is probably one of the big hurdles. So pharma is understandably reluctant to share clinical trial data for a variety of reasons. So establishing a way, and there's also issues around ownership and all of that kind of stuff. But so establishing a way for partners to collaborate with somebody putting in a bunch of data, somebody putting in a model, letting them learn, train, validate, whatever it is, without actually directly being able to extract the data. So I think that would be, I mean, right now, so there are some platforms like that, but we need something that's like big and universally understood, because it's partially a trust matter.
And I think to your comment about connecting the, so when I think about how the chasm between technology right now and AI and the researchers, clinicians, technologists that support it, right? There is a gap right now, and there continues to be a gap of how we unlock that power, right? And how we connect the skill sets of the clinicians with the needs that they have at the bedside, with the research that's being done and the power of AI. We need to continue to we need your help as a higher ed institution to help us create our automation and our skills and our services in a more linear fashion to help support that and automate that interaction and unlock that power. I think as you continue to have siloed clinical use cases and researchers that are doing things uniquely and differently, there's a much broader benefit when we can bring that all together. And I think that's what we see as a big
Great. Thank you.
Can I add one?
Please do.
One,
Please
and
do.
that is, and this, we've touched on this a little bit before, data standards. That is like such a boring thing, but it would make such a huge difference. So, you know, obviously in radiology, the reason we've been able to do more AI research, like, you know, we were doing it before GPT made it cool, right? Is that we've had DICOM. And we had DICOM because basically, you know, GE, Philips, Siemens, you know, a few big companies made all the equipment so their data engineers could get together and coordinate on a data standard. And it's much harder in other spaces. In EHR, in pathology, there aren't those established data standards. It's so much more difficult. So if people could collaborate to come up with a data standard, that would accelerate all of this dramatically.
Awesome. Let me open it up to questions or comments from the audience. We've got time for a couple of questions. Let me turn it back to the panel for those that are interested in answering. We've mentioned academia-industry relationships. Could you envision individuals from both components just working together in not only in data acquisition, but data analysis, let's say outside of clinical trials? Would that be feasible?
I mean, I could certainly see partnerships with people going back and forth. I mean, you know, I know that Merck has had folks working within Merck who are, you know, coming out of academia and then going back to academia. So collaboration by people seems, you know, quite possible.
Dr. Goldmacher, thoughts?
Shane, Khalil, no worries. The AWS Scholars Program is an example of that, right? It's exactly what he mentioned, is the interaction and the engagement between higher education and the research being done and bringing that in-house at AWS, at Microsoft, at Google, at others. We look to collaborate as freely and evenly and easily as possible.
Opportunities for joint fellowships, maybe?
Absolutely.
I mean, Dr. Riley, you do a lot of that.
You know, Anil, you're passionate about this area, but I think it should be possible that there are both industry trainees who are in industry who spend time in academia working with academics as part of projects that are collaborative and structured projects. But in the reverse, there should be possibilities. For example, you know, getting access to the clinical trial data. You know, well, that could be part of a collaborative framework where an academic postdoc or an academic faculty spends time with industry and works really deeply with the data the industry has, as well as bringing in their clinical background. I think, you know, the odyssey with George and colleagues has worked a fair bit with industry partners as they've federated and distributed analysis. That hasn't been restricted only to clinical partners. So there are models out there to really have people placed and to drive the project. So I think now is the time for that, especially given the current environment. How do we create models of collaboration with industry that are much more open and therefore drive, I think, opportunities?
Okay, if the audience would join me for thanking the panelists. It was a great discussion. Thank you.